Welcome to the show. We have our very exciting guests, Brenda, Cynthia, Jacqueline. Hi, to the show on Zoom and talking about some more healthcare disparities as it relates to mental health. I think that you would really enjoy your show. So please sit back, have a seat, and we will begin. All right, let's begin with this great question I want to address you. Cynthia, matter of fact, last week we didn't give any information on the hotline. If anyone watched our show last week, please do that. Sorry.
We had a chance to touch on different mental health issues with depression, and we even touched on a little bit of suicide. But if you have a real problem with suicide and you can't reach out to your local agencies, don't worry about that because there's a national suicide prevention hotline. And that number is 1 800 273 8255. You can call it 24 hours a day, 7 days a week. It's available in English and Spanish. And if they need to find you more help, they will help to find it in your language as well. Right. So there are resources for you just in case you need them. Also, we're going to go on to more fun things about depression and mental health and all the good suicide stuff. So for me as a nurse, it can be really hard to recognize the difference in symptoms that are indicative of a temporary versus contextual sadness and that signal that depression. And so we're going to keep touching on that with Brenda today, and she's going to help give us some more insight into that. Go ahead, Brenda.
Thank you, Cynthia, and also Gayla. I'm going to be talking about the different variations of depression, and I'll list them out and then I'll kind of backtrack and go into more specifics in terms of major depression would be one, persistent depressive disorder, also bipolar disorder, seasonal affective disorder, which is also known with an acronym of SAD, psychotic depression, peripartum or postpartum depression, and premenstrual dysphoric disorder, seasonal depression, as well as atypical depression. Now, when we look at major depression, major depressive disorder is also known as unipolar or clinical depression. And I'm going to give you a technical term, which is it's characterized by a persistent feeling of sadness, lack of interest, and outside stimuli. You might have this type of depression if you have 5 or more of the following symptoms on most days for 2 weeks or longer. And that would consist of loss of interest or pleasure in your activities, feeling of worthlessness or guilt, negative thinking with inability to see positive solutions. If you're feeling restless or agitated, inability to focus, when you lash out at loved ones, having irritability, withdrawing from loved ones, increasing in sleep, exhaustion and lethargic, morbid or suicide thoughts. And even something that we don't normally think about is when we gain weight or even lose weight. And if you have, again, 2 on most days for at least 2 weeks, any of those symptoms, you need to see your primary care physician. They can certainly recommend a therapist for you to see. Persistent depressive disorder. When we look at that particular depressive disorder, it is also known as persistent depressive disorder. This could last as a long term of depression, which could last for years, and It could also interfere with your daily life, your daily work, and also your relationships. Bipolar disorder.
Mm.
Sometimes it's referred to as manic depression. It is a mental health condition that causes extreme frustration in your mood, your changes in energy, thinking, behavior, and sleep. Also, look at those disorders and write them down, as we mentioned in the last segment, because those things are key when you're talking with your physician about maybe having this disorder. Seasonal affective disorder, which is also known as SAD. This happens to individuals who are depressed, and it's related to the seasons. If you're living in a particular area where it gets dark and it stays dark for a long period of time, you may develop the seasonal affective disorder. The other thing you should look at, these are other areas that is related to SAD, which is heaviness in your arms and your legs, frequent oversleeping, craving of carbs and weight gain. Okay, that's me. Relationship problems, because I love carbs. Don't we all love carbs?
Yes, we do.
Uh-huh.
They are my friend.
Right. Carb is our friend, but it's not good for us if we have too many. Psychotic depression. With the National Alliance on Mental Illness, there is around 20% of people with depression who have episodes that are so severe that they develop psychotic symptoms. And these diagnoses is a major depressive disorder, which in these psychotic features, it may be given to individuals who are suffering from what we call a combination of symptoms, that is depression and psychosis. Okay, so the other area is peripartum or postpartum depression. This is when individuals are feeling sad, they have crime bouts. This certainly happens with individuals who have just had a baby.
Mm.
And as Cynthia's raising her hand, and they also call it baby blues. So
Mm.
don't be afraid to talk to your physician, your gynecologist, your primary care physician about this, because it's not anything to be shamed about. It's just getting it out there, letting them know that you are feeling this way. And when you do have the peripartum or the postpartum depression, these are some things that, some signs and symptoms that you may feel, like feeling down or depressed for most of the day or for several weeks or more, feeling distant and withdrawn from your family and your friends. You may have a loss of interest in activities. That does include sex, believe it or not.
Ladies or men.
Yes.
Okay.
Changing in eating and sleeping habits. You may also feel a little tired most of the day. You may feel some anger and even irritability, having feelings of anxiety, worry, panic attack, and even also racing thoughts.
Mm.
And again, you need to just talk with your physician about it. And also for your family members, your spouse, significant other, baby daddy, whomever, when talking with your physician about these things, especially after just having a baby, prior or even after having that baby, the family member may not understand what you're going through.
Mm.
So having them in the room with you and you're talking with the physician, you're getting more information and education about what you're going through is certainly going to help them. because they want you to just bounce right back. Oh, she just had that baby. Oh, 6 weeks later, oh, she should be ready for sex and everything else, but you may not be. So certainly for our audience, make sure that you talk to your physician about that. Some premenstrual dysphoric disorder. There again have been studies based upon this, that about 5% of women do experience that. So make sure that you take your younger teens. They just not mad at you,
Mhm.
but there may be something else going on with them to address those issues, because a lot of times that happens in the the younger girls, and they don't even know that they're going
That's
through
going
things
on.
like that.
Yeah, yep, exactly.
And that's about it for me. I'd like to now turn it over to Jacqueline. She's going to talk about gender. She's going to talk about the LGBTQ health discussions. And she's going to let you know what that acronym means for the community and their health discussions. Thank you.
Hello again.
Hello, Jacqueline.
Hey,
Hello.
Kayla, Brenda, Cynthia. It's good to be with you all again. The topic I'm going to talk about is gender, the LGBTQ health discussion. Now, what is LGBTQ? Most of us have heard it or have seen the acronym, but what it stands for is lesbian, gay, bisexual, transgendered, and queer. There is now, they have added the plus sign at the end of that, which is an inclusive term for people who don't fit into the traditional categories of gender and sexuality. So it covers a lot of people.
Yes.
I'm not saying that I'm in that group. I'm cis, but I was just saying plus.
Plus,
That just recently happened in the last few years. They added that plus in there, but yes,
Yeah,
that's
they have
really
the
important.
IA too.
Yeah.
it's real important to know no one is excluded. This category is not the traditional of what we consider as gender. And then with this acronym, the other acronym would be straight, which means people who do identify with their identities, either male or female. So covers everyone. I don't think we have anything for aliens yet. So
Maybe they're in the plus group. I don't know.
Well, they just did a trip up to the space. I know you all saw that.
Right.
We don't know what's going to happen.
we
So
don't
get
know
ready.
yet.
Get ready.
We're going to go with what we
Our
have.
billionaires are able to do it now. So let's
Right.
try to disturb something up there. We hope not.
So I will be I will be using the acronym LGBTQ plus, and so you'll know what I'm talking about. Okay, so regarding the LGBTQ plus, when you go in to see a doctor and complete the patient information forms, a lot of the wording on forms state if you would like to be addressed as the person you were born as, meaning male or female, or will you like to be addressed as the individual you identify by now? So I think that it is good that these forms have been updated, and because we have a large community, and I'm not just saying in where I live, but nationally, of the LGBTQ pluses. So everyone has a sexual orientation and gender identity. Sexual orientation is who you are romantically or physically attracted to. Gender identity is the internal sense of being male, female, both, or neither, which is separate from your biological sex.
Yeah.
So what that means is internally, you may be born male but identify as female, or you may be born female but identify as male, or you identify as something other than the norm, the natural male or female.
Mhm, mhm,
I
Okay,
identify as pillow.
mhm, mhm.
that's so soft and fluffy.
I am soft and fluffy.
So, people who have a different sexual orientation or gender identity from most people fall under the umbrella term LGBTQ+. It is really important to know that identifying as LGBTQ+ is not a mental illness or disorder. So I wanted
Thank you,
to
thank you,
stress the not.
thank you, thank you.
You are
Yeah.
Very
All
good.
people,
Mhm, right.
Oh,
the peoples be the peoples.
Mhm.
so because you identify with that acronym does not make you mentally ill. However, just as men and women, straight or gay, whichever you identify as, mental illness comes in different ways. Okay. So, although being LGBTQ is absolutely not a mental illness, many LGBTQ pluses people experience mental struggles. The bisexual and transgender community have the highest rate of mental health concerns with the LGBTQ plus population. Younger members of the LGBTQ pluses community struggle the most with mental health concerns of all the age groups.
Yes.
And that is very, very broad. All the age groups, no matter what the age.
Mm.
Some is even as young as 8 years old, I've heard, are now identifying themselves as LGBTQ pluses. So children, adult, teens, it covers every age group. Most LGBTQ pluses individuals are incredibly resilient and will thrive in the face of adversity with the help of supportive family, communities, and peers. One study even found that the LGBTQ plus people use mental health services 2.5 times higher rate than their straight counterparts. That says a lot. They're not afraid to even investigate or to even admit that there might be having a mental health issue or crisis. So,
True.
And mental health could be genetic. It's not who you are as far as your identity. It could be something that you can actually be born with, because major depression, you can pass that on. Alcoholism, you can pass that on. You know, bipolar, you can pass that on. Anxieties, you can pass that on to your loved ones, to your children. And
Yeah.
it can skip generations. So yeah, very important, Jacqueline.
however, they are also at particular risk for experiencing shame, fear, discrimination, and adverse and traumatic events. Women are more likely to have been treated for a mental health problem than men. 29% women compared to 17% of men. This could be because when asked, women are more likely to report symptoms of common mental health problems than men are. Women are also twice as likely to experience anxiety as men. Men are more likely than women to have an alcohol or a drug problem. So when it comes to this demographics of people, women are more likely to have experienced issues such as, I don't know, sadness, depressive type symptoms of tiredness, just not with it, menstrual issues, than men are, who show more or a higher rate of alcohol or drug abuse. So that is really becoming a big issue, and it can be a pretty big problem when you're compounding other issues, as Gayla pointed out. Some of these things can be genetics that we are born with, especially with the alcohol and the drug addictions.
Mhm.
LGBTQ plus people are at greater risk of poor mental health and well-being. As a minority, you may have to deal with difficult experiences like discrimination because of your sexuality or gender identity. This can have an impact on your mental health. This fact sheet looks at the issues that may affect LGBTs pluses people and how to support. Research shows that mental health problems like depression and anxiety are more common in the LGBTQ plus community. There are specialist LGBTQ pluses, charities, and mental health services that you may be able to access for support. Go back up here.
I would like to interject a little bit and say something too. I was born with a birth defect on my hand. See, if the audience can see. It had no bearing on me physically as far as doing activities, but in the workplace, I felt a lot of discrimination in the workplace.
Wow.
Because people automatically thought that maybe I couldn't type or type as fast or do certain type of things that were required in the workplace because of my hand. And even after I got my bachelor's degree, that didn't say anything. I still felt the discrimination in the workplace, and that's why I went and became self-employed and remained self-employed because of those discrimination. So I get it, and I understand with our LGBTQ plus community when it comes to discrimination, because unfortunately this is still happening, it's still real, and it still is going on. And with all of that to be said, it does cause some depressions, some anxiety, because we're human beings. And so, when we're not able to be accepted into society as just a person. So I wanted just to touch on that, and we'll go into more detail that on another series about people that's dealing with physical disabilities and in the workplaces. But go ahead, Jackie. Jackie, you have something else you want to share with us in the area? Yeah.
Yeah, I was going to talk a little bit about access of insurance.
Mhm.
I hear some background. In a survey of the LGBTQ pluses people, more than half of all respondents reported that they have faced cases of providers denying care, using harsh language, or blaming the patient's sexual orientation or gender identity as the cause of an illness.
Mhm.
Fear of discrimination may lead some people to conceal their sexual orientation or gender identity from providers or avoiding seeking care altogether. And this kind of coincides a little bit with letting your physician know your vices. And if they're not given, if they're withholding or not revealing that they are LGBTQ or anything like that, then the scope of care can be affected because of maybe illnesses or diseases that they may have. So insurance providers, I think, are getting a little bit more, I'm not sure, allowable for some of the things that are or the cares that are billed for, and that's something that Brenda could probably talk a little bit more about, but these are real issues that this community of people do face. Treatment issues. Approximately 8% of LGBTQ pluses individuals and nearly 27% of transgender individuals report being denied needed health care outright, just flat out denials. In mental health care, stigma, lack of cultural sensitivity, and unconscious or conscious reluctance to address sexuality may hamper effectiveness of care. And evidence suggests that implicit preference for heterosexual people versus lesbian and gay people are pervasive more among heterosexual healthcare providers. So it's a big disparity there, in which the gap needs to be closed, shrunk down. And so this is pretty much all that I have, but I think that Brenda might be able to expound a little bit more about the insurance and how patients are being billed or
Not being billed, right,
Not
right.
being
Or
billed.
can't be billed for because their primary doctor feel it might be another way. So Brenda, you want to add something to that?
Yes, that's absolutely true. Thank you. Even more so over the past 10 years, when the coding has changed in terms of when you go to the doctor and you have a diagnosis, they code that in with numbers, and that's what goes to the insurance company that says what's wrong with you, and it's called diagnosis coding. It has changed a lot, and they are more up to date. That's why the demographic forms have been changed. When you go in and you complete that form in your doctor's office and they ask you, what do you prefer as, because they're respecting what you go as an individual also too. But when it comes to your health care, they put the correct information in terms of if you're a male, they put what you're born with. I also know too that individuals who are going through surgery to change their gender, they do have to go through, before they have the surgery, they do have to go through a lot of therapy, mental health therapy, in order to, that's part of getting that approval to have that surgery done. So that again is important for our audience to know that you will go through a series if you're facing those particular issues or concerns. You do go through therapy as a part of making sure that you're okay mentally with those changes that's going to be happening to your body. So insurance is definitely aware, and they are changing with the times. So
Cynthia, you want to add something to that, Cynthia? You want to add something to that before we go to our next topic?
Maybe not on insurance, but definitely on the fact that when it comes to healthcare providers, we are missing information. We don't necessarily are able to like not have a bias toward it of some sort. So in the LGBTQIA plus community, teaching cultural competency is really a first step toward overcoming those challenges, but they aren't enough. And we have to make an active effort to be respectful to all patients, regardless of their sexual orientation or gender identity.
for sure.
So just treating people as people and trying to leave your biases at the door and trying to understand them as the individual that they are. It is very important for them to have even competent care.
So with that was a great topic. And we'll have more to come on our community, which we love so very much, which is the LGBTQ plus community. And I would like to say that we love you guys very much. Let's go to our next topic. And our next topic is addressing the importance of taking your medication as prescribed and communicating with your pharmacist. Don't forget about your pharmacist, because your pharmacist is a doctor too, on the medication of what you actually are prescribed. So let's start with Cynthia. Hey, Cynthia, can you give us something on that? As a nurse? And I said RN nurse. She's an RN, so go ahead.
I am. And like, when you really kind of think about healthcare, for me, at least in my mind, technically, I've been dealing in some form of healthcare since I was a child because my mother's in healthcare. And originally we did healthcare around animals. So having an eye for even noticing when someone can't say something, I get it from that. And then my mom, I helped educate myself through what she did. And she was a lab tech for a long time, who also was a phlebotomist that did blood draws. So, and then she went on to PA school at one point, and now she's working on a master's degree. So I get a lot of extra help from her. But on the importance of taking your medications as prescribed and communicating with your pharmacist, the American Journal Medical Association notes that among adults with chronic illness, 30 to 50% of medications are not taken as prescribed. In the United States, it is estimated that medication non-adherence is associated with 125,000 deaths, 10% of hospitalizations, and 100 billion in healthcare services annually. So what we do as nurses is we do try to help patients and individuals receive the information that they need about their medication. It might be their dosing schedule. Did we go over that? Do you understand the instructions? What are the side effects? And when is that refill schedule? You can also go over this with your pharmacist too. We want to give it to you in your preferred language. So ask for an interpreter if we don't know. Like if we're not speaking your language, you might need more help. In addition, we can work to provide a provider that is more acceptable to their culture on top of that, not just an interpreter. So at least referring out to someone else. So we have to also deal with medication adherence and the risk with non-adherence. And so that non-adherence can cause you to have more out-of-pocket issues with the cost of your medication and with the escalation of your illness. And then if you don't have access to maybe the money that you need to through your insurance or through whatever co-payment plans that you have, and now you're not taking your medication correctly, it's not necessarily that you didn't want to take it or that you didn't understand it, but you're trying to make the medication last longer. And it's not as effective that way, and you can actually still hurt yourself that way.
So can I interject on that too? Because, you know, by talking to your pharmacist too, and I don't know if you was going to say that, but
that's what I was about to talk about, is like going back.
yeah, and because there's programs that depending on what that medication is, they could get possibly free medication.
That's right.
Absolutely.
Yeah, and don't even know it until they ask their pharmacist about that. Not to the point where they have to discount, actually free medication.
Absolutely.
Because a lot of these pharmaceuticals have like little foundations that they help and give their medications out to people that are unable to continuously to purchase or to purchase them. Go ahead, Cynthia.
No, you're right. And with the expansions and some of the Medicaid practices, we're able to also help on that end too. Not just with discount plans and coupons and those foundations and federal financial assistance. When you have that non-adherence though, you do get more of an increased risk of hospitalization, and you can have more chances to deal with heart failure, diabetes, or even psychosis. And for instance, even over-the-counter meds can be problematic. So if you don't understand the side effect of a med, and again, please talk to the pharmacist. They're right there when you're buying it normally.
And they know it. They do.
Yeah,
They know it.
Absolutely.
They'll know if your medicine is clashing. Because that's
Absolutely.
a big thing. I know everything. Hey, Brenda, what do you want to share with us about that?
I'd like to thank you, Gayla and Cynthia. I'd like to also share that when you are connected with a pharmacist or pharmacy, um, just to name a few, such as Walgreens, CVS, and those, um, try to stick with, if at all possible, stick with the same pharmacy if you can. And the reason for that is you build a relationship. They know how to communicate back and forth with your doctor. They sometimes, because they will know who you are when you walk into the pharmacy,
Mm,
and they build a relationship with the pharmacist because, as Gayla said and Cynthia mentioned, there's what's called a contraindication, meaning that there are side effects to what you are taking.
mm,
Every time you get your prescription at a pharmacy, they give you a pamphlet. Usually it comes in your um, uh, it
your bag,
comes with your
Right on the back.
packet
yeah.
of your medication. And so read that. It is very important that you stay on top of what the side effects, what the contraindications are, because if you don't know and something starts to happen, you don't know what that medication is doing to you. Okay. And so sometimes it's just trial and error when it comes to when you go to your doctor and you list out the symptoms and what you're going through. Um, Sometimes you may miss something. As we mentioned in other segments, list the things that your body is going through, because somebody else in your household may be taking that same medication for the same diagnosis,
Mm,
but each one of you may have something different going on.
right.
Someone may have
Valid.
leg cramps as a result of taking a high blood pressure medicine. Somebody else may feel a different way. So your same symptoms the symptoms may be different, even though you're taking the same medicine, same quantity, same time of the day as maybe another family member. The other thing too is that your caretakers, people in your house, if they're helping you with your medicine and making sure that you're taking it on time, let them know what you're taking. Let them know what changed in your medicine. That's why it's a good idea to list out. And I know when you go to your doctor's office, they will ask you, "Are you still on?" And they'll begin to rattle off all this medicine, and
I
you
was
just
on that
begin to
thing.
nod your head, like, "Yep, yep, yep, yep." And I know for me in particular, there is a medicine that they prescribed to me 5 years ago, and that's when I had that surgery. I haven't had that surgery, but it's still listed
Yeah.
on my drug list.
Till
And
you take
so
it
I
off.
just say,
Mhm.
right, I just,
Yeah.
I have been known to say, "Yep, yep, still taking it, yep," whenever. I have not taken that medicine. So me, as even working in healthcare, sometimes forget that I should say remove that one,
Right. Very
you
important.
know,
Yep.
but you
Important.
if you don't have that list in front of you, you just begin to nod. "Yep, yep, I'm taking that. Yep, I'm taking this. I'm still taking that." And or uh in my oldest sister's case, she just limited what she was going to take in terms of her insulin for her diabetes. And the
Mm,
reason she did that is because it was so expensive.
mm,
And as Gayla and Cynthia mentioned, there are programs that are out there. So if you don't say anything to your doctor about taking the medicine and that it's too expensive, they will never know that it's too expensive for you. And that gets back to the copays. That also gets back to at the beginning of the year, you have a deductible you have to meet. So all of those things play in. If you've got a cancer diagnosis, there are programs out there that help you with that expensive medication. I work with cancer doctors, and there are programs that take care, sometimes in many cases, your copay that you have to pay, as well as that expensive drug. So your out-of-pocket costs may be a whole lot less. So again, speak up, speak out, and let the provider who's taking care of you know what you can and cannot afford. And also with your pharmacist, sometimes, they know of programs
Mhm.
that you
Right.
can qualify for
Right.
that your physician may or may not know.
Mhm. And they definitely know medications that clash together.
Yes,
They definitely know that. And so, Cynthia's like, oh yeah, we that's a whole big topic to talk about that. I mean, as when I was practicing as a mental health provider, and seeing clients, and clients had mental health issues as well as extensive medical problems, um, and found, and was finding out they were still feeling depressed and sad, and not feeling good on a daily basis, and come to find out their medication was clashing, because
yes,
when you have multiple doctors, we hope that everybody is coordinating of care, but sometimes it takes you to advocate for yourself.
right,
So when you go pick up your medication, it's so simple just to say, you know, doctor, or whomever the person is, can you look at my profile and look at
yes,
all the medication that I'm taking, and seeing if they work together?
yes,
You don't have to have a broad knowledge of medicine to just ask, are they working together? And that means, are they clashing? Are they not clashing? Because
right,
that could cause you to have sicknesses that it might take your doctor. It might take a team of doctor to find out, because you're going to so many multiple physicians. And then also too, you didn't share with your primary doctor, and they don't have that on their profile because you forgot to bring your list of all the medications that you are on. So that's
right.
really important. So let's go to our question with Jacqueline. Jacqueline, health issues that arise in certain ethnic group. Really good. This is really good. What can you share with that?
Thank you, Kayla. In some cultures, when a woman is seen by a doctor, her husband will be in the room, and he is the only one that speaks to the doctor and not the woman herself. Um, this is quite common, and
We're the 21st century, and that still goes on. But go ahead, Jacqueline.
it still goes on.
It is hard to get in for, I'm gonna say, as a nurse, this is a situation that is very hard sometimes to be like, who do I talk to here? But I need this person to answer the question because I need them. And then that person's answering the question. And you're like, ah.
That is so true.
It is.
Many unfamiliar high risk and high vulnerability statuses, identities, and roles are becoming commonplace among mental health service settings, including migratory workers, international workers, skilled and unskilled, immigrants, temporary immigrants, undocumented immigrants, refugees, asylum seekers, war victims, torture victims, and international students. So we have a very large demographics of people in our society today. And because of barriers, language barriers, can make it really difficult when they become sick or have an illness. Patients in each of these bring unique needs and problems requiring complex service resources that must be acceptable and accessible.
Mhm.
So there are problems with culture shock. Acculation, saying that correctly, assimilation, uprooting, language competencies, and scores of economic, housing, and medical problems. Many services are centers service centers are ill prepared to address and treat these problems.
Yeah,
So
yeah.
our communities are are growing in different populations. Yes, the why, where, when, what. Our communities are growing uh, with, uh, for me, in my community where I live, you see a large population of Asian people, uh, Sudanese,
Mhm.
African, Native African people who are having these problems and issues when their children get ill or sick and they need medical services.
Mhm.
So there are many service centers that are popping up in these communities to address the needs of these different cultures of people. So what I would consider as being a Black American in my culture is much different than what my counterparts, African Americans, true Africans, would do for healthcare and would go for healthcare. So it's much, much complex, and it's much, much different because I, as a Black American, grew up here in America and was, already into what our culture does. Uh, Speaking of my parents, so my assimilation or culturalization was kind of automatic.
Right.
But for those coming from, or the African American people who are truly coming from Africa, their assimilation is much different.
Mhm.
So
Sure.
And it may not even be a lower type of difference. Like it may be just that they're used to more access of care, even from their particular African country, because they actually may have a socialized medicine, but they're also used to more doctors, nurses, and people that are assisting them looking more like them. And so just even the coming into the American system, how everything looks so much different from them.
exactly.
True.
Cultural
And they
competence.
may, yeah, and they also may use a lot of herbs and um, um,
Holistic.
holistic medicine to treat their condition versus going to the pharmacist and going to the doctor. You know, a lot of individuals may go on what their parents did
Right.
or their culture or their family orientation, whatever they did to treat those conditions, and really it may or may not work in what's going on with them now.
Mhm.
That is all correct. Um, Cultural competencies. Excessive reliance on the delivery of mental health services rooted within Western assumptions, knowledge, and practices can have perilous consequences. Indeed, these can often produce a range of irritonic or irogenic, meaning treatment included problems.
Mm.
It is essential that mental services be responsive to ethno-cultural differences and casual models of health and disorder patterns of disorders, standard of normality, and treatment alternatives. So
I want to break this down just real
break it
quick.
down.
I want to interject because you said a lot of big words in there, and I don't want to lose our audience of those big words. I mean,
Go
to
ahead.
kind of like to bottom line,
Bottom line.
we need more community health care workers in the community that assist our medical practitioners, and they're called navigators as well. I
Yes.
know that sometimes some hospitals, your major hospitals, they're trying to employ some of those community healthcare workers or navigators within their system, because these individuals work with everyday people, and then they work with various different cultures to
Right.
help them navigate through our medical system,
Right.
where that sometimes, the physician or the nurse may not have the time, but that's what their roles and responsibilities are, to help you understand those questions that you might not understand. Like,
Right.
Jacqueline said a whole lot and a whole lot of big words, and you probably like, I've heard them before, but I don't get them. So I am hoping that Nebraska and other states start employing and finding a way to get community healthcare workers employed where that they can make as a job and go out there and help the community, because right now, as it stands in Nebraska, a lot of our community healthcare workers are on certain type of grants, and if the grants don't get funded, that program ends, or they're doing it for free, like me. I've been a community healthcare worker for more than 10 years. And I am certified, and we are still today trying to find funding where that, we can make this into a part or a full-time job for something that is so absolutely needed.
Right.
And especially when we are still faced with this global pandemic, and people still need a lot of questions and they need a lot of answers to their questions.
Right.
So I'm hoping that we try to work together, try to pull together our government, our state government, our city governments to find a way to employ these community healthcare workers or navigators to be able to go into the community and into people's homes and explain to them in the language that they understand, so that we can eliminate some of these really strong barriers that's been going on for more than 10, 15, 20 years that we are still talking about today as barriers. You understand? And we should not be talking about them as barriers like that. But Jacqueline, do you want to end up and continue to say something last before we close our segment out?
Thank you, Gayla. I agree with you wholeheartedly. And I think our greatest example is what our nation has just experienced with COVID-19. And as the need arose for people to get testing and for people to get vaccinations, our city leaders, nation leaders, national, federal government jumped right in and opened clinics and opened mobile units, and they made a way and found a way for people to get testing and to get it done for free. And now as we see the vaccination come on the scene, I mean, they made places available in unsuspecting places, churches and gyms and schools. I mean, so it's not that
and your local pharmacy.
And your local pharmacy, exactly.
And your grocery stores.
Yeah.
Exactly. So it's not that there's a lack of places, but I think legislation get out there, that these places that these different demographics of people that are parts of our cities and towns and states, and they pay taxes and what have you, that these things could be made available to them in their communities. And so I think you hit the nail on the head that
Go ahead, Jacqueline. Go ahead.
That it's not an impossible task, but that it can be done.
So that brings us to our last question. But personal beliefs and the relationship between medicine and a personal belief. That is so important, because a lot of personal beliefs has caused people to not take medicine, scientific medicine that we have in our community. And definitely we are not trying to sway anyone to not believe what they believe. We just want to touch on this because we want people to know that there's options.
Right.
There's options. And their options could be changing a dynamic of a family that has been doing something the same way for hundreds of years, and they might want to step across and say, I want to try it this way, mom, dad, grandma, grandpa, or they just want to do it themselves, so we want people to understand is that there are many options out there. And so let's roll it with Cynthia. Want to touch on that real quick?
With personal beliefs, when it comes to nursing, how it's currently being applied, I will go with that right now because I know me and you, we're going to be talking on that more later.
Mm-hmm.
So I feel like it's more of a touchback to you have a belief system. However, within the context of that belief system, do you not see the individual in front of you as a human? And so at the end of the day, if they are a person that you need to help them understand care and to give care for, whatever your personal belief system is, you have to leave it somewhere in your back pocket and sit on it. Because we're supposed to be there to help someone feel better,
Yes.
to get to a better health outcome, maybe to get them back to their normal health status. The thing is, you cannot sit there and spend all your time in politics with that, regardless of how your staffing is for the day or regardless of how news coverage is. And so for us as healthcare workers, at last for me as a nurse, humanity should be first and foremost. That's what I'm there to handle. What are the questions that I need to address? How did you come in today? And what do we do to get to a better state? So to that, where's Brenda?
And I would just like to add, thank you very much. I would just like to add, it is nothing wrong with getting a second opinion.
No.
If you don't agree with the first opinion, go get a second opinion. And that's what I'd like to add to that. Thank you.
Jacqueline?
Don't isolate yourself.
I'm good at that.
No. You have a mental illness, you may be reluctant to tell anyone about it. Your family, your friends, or a member of your community can offer you support if they know about your mental illness. Reach out to people you trust for compassion, support, and understanding. It may not be anyone in your household. It may be your neighbor. It may be your doctor. Just don't isolate yourself.
And it may be your coworker, it may be anybody, because you might be feeling, because of your personal beliefs or the way you were just raised.
True.
The way you just normally was raised, it's maybe different from your friends, your neighbors, your coworkers, and you might have questions about that. And so I guess the bottom line to that question is that try to just reach out to whomever's the closest to you for some guidance and help. And if you feel that you need some help in any areas, there are always 1-800 numbers that you can call, national numbers that you can call to talk to professional people to whatever subject is. There's 1-800s for mental health. There's 1-800s for bipolar. There's 1-800 numbers for depression. There's one national 1-800s for alcoholism and drugs. So, hey, you know what? That's where you can Google, ladies.
Right.
You can Google those national numbers. And then you know what? Then you're talking with a professional person on the phone that you don't know. And once your conversation is over, your information is confidential and nobody has to know that you did that but you.
Right.
So with that said, anybody else want to close up and say anything? Brenda, you have some last minute things you would like to share?
No, I think this has been an excellent session.
Cynthia?
Well, since we were talking about 1-800 numbers, Substance Abuse and Mental Health Services Administration has a 1-800 number. And I can't say the acronym. I keep trying. I think the H is silent in when I say it, but SAMHSA? I don't know. I can't say it.
Mhm,
But
Samson.
National Helpline is 1-800-622-HELP,
Mm.
which is HELP, or 4357. Again, that is 1-800-622-4357.
Mhm. Thank you so much for that. Jacqueline, you have a last minute comment you want to say before we close this segment up with the show?
I think this was a great segment and looking forward to the next one.
Thank you so much, audience, for watching the show. Stay tuned to us next week with Cynthia, Jacqueline, Brenda, and myself. Good night. Bye-bye.